So this is an auspicious occasion where we have gathered to rub minds on what needs to be done, what is being done, and future directions in this area. So I welcome you all once again, and I move on to our distinguished moderator, Taylor, to continue. Thank you.
Thank you, Dr. Musa, for that introduction. Um, so welcome everyone to the AI4PEP World TV Day special event. Just checking, can you hear me well?
Yeah, we
Great,
can.
awesome. Okay, so my name is Taylor Cargill from the AI4PEP communications team, and I'm honored to welcome you all to this special event. This event is being organized as part of the events planning committee of AI4PEP. And as Dr. Musa mentioned, our theme today is AI for a TB-free world, commit, invest, deliver. Um, so I'll just briefly walk us through um, before we get started into things, just for those who are unfamiliar with AI4PEP, we are the Global South Artificial Intelligence in Pandemic and Epidemic Preparedness Response Network. It is a global research network that connects researchers, health practitioners, community engagement specialists, and AI experts from all across the Global South, from Africa, Asia, Latin America, the Caribbean, the Middle East, and North Africa. So our aim is to leverage responsible AI solutions to strengthen equitable healthcare systems and power inclusive research through Southern-led initiatives. So the QR code to connect with us is available on the screen. So please feel free to scan and stay in touch with us. So just to briefly go over our agenda for today, sorry about that. As we heard opening remarks from Dr. Musa and goodwill messages, with brief comments about the key role that AI research can play in catalyzing solutions to address the unique needs of the global TB crisis. Are then followed by our panelist presentations, where our esteemed panel will deliver presentations discussing some of the regional contexts of tuberculosis challenges and solutions around the world. They're going to share with us their unique perspectives in AI research, healthcare, and governance. And then after that, after a brief summary or synthesis of the talks, we're going to move into our panel Q&A session, where our panel will answer some questions from the audience and steer an engaging conversation. So we want to encourage our audience to please drop questions in the chat throughout the session. These will be saved for the panel discussion later on. So back to the theme. As a reminder that our event theme for today is AI for a TB-free world, commit, invest, deliver. And it echoes the broader World TB Day theme, but with a specific emphasis on how we can leverage AI-based tools and methodologies in the fight against tuberculosis, and explore challenges and opportunities for digital innovation as we strive to shape a truly TB-free world. I'll leave the floor for Dr. Musa for any additional opening remarks.
I think that's fine. Taylor, we can proceed. Thank you.
All right. So moving on, we'll move on to introducing today's panel. So we're very privileged and grateful to have with us a panel of 5 amazing experts who are going to give context on AI in the fight against TB at their national and regional context. So just to go through who we have on our panel, we have Dr. Yaya Tayalati representing AI4PEP Morocco. We have Dr. Patricia Espinosa Lopez representing AI4PEP Peru. We have Dr. Hasirul bin Hashim representing the Kuala Lumpur and Putrajaya Federal Territory State Health Department in Malaysia. We have Dr. Tani Sagna from the National Center for Scientific and Technological Research in Burkina Faso. And we have Dr. Mohamed El Mzibri representing the National Center for Sciences and Nuclear Techniques, or CENESTEN, in Morocco. So our first talk today will be from Dr. Patricia Espinosa Lopez from AI4PEP Peru. Dr. Patricia is a medical doctor associated with the Cayetano Heredia University in Peru and holds the position of Associate Investigator at the Institute for Tropical Medicine Alexander von Humboldt where she also serves as the coordinator of the Tuberculosis and Respiratory Infections Research Unit. Her work focuses on conducting tuberculosis-related projects, including epidemiological studies, immunological research, and the validation of innovative diagnostic methods. Dr. Patricia is also the current project lead for AI4PEP Peru, which focuses on applying AI for screening and early detection of respiratory diseases like TB. Dr. Patricia, over to you.
Thank you, Taylor. Thank you, everyone. Just before to start, I want to show you if you can hear me well. Okay, can you hear me?
Yes, we can hear you.
Thank you so much. So let's share my screen now. Okay, so now to move on with just a brief introduction about using AI-based solutions for TB control. I'm going to make just a brief presentation and a brief introduction about what is the importance of TB. As many of us maybe we know, tuberculosis is one of the leading causes for mortality worldwide attributed to infectious diseases, and as well is the leading cause for death among about people living with HIV. Around 10 million of people have been diagnosed with TB worldwide, and as well is resulting in more than 1 million deaths around the world. So here's some data from the last global tuberculosis report for 2024, when maybe you can see the majority of these high burden settings are focused on the global south as well in my country. Something that I want to highlight for this introduction is maybe we as researchers, we as implementers, maybe we can think about how is the trends during the last years about TB incidents. And now you can see here these trends by region according to the WHO. As a researcher in Peru, in the Latin American region, I can see the region of the Americas. Well, can you double check if you can hear me now? Sorry, I can see some comments in the chat box.
Yes, I can hear you.
Okay.
I can hear you too.
Thank you. Okay, as we can see here now in the region of the Americas, even though that we have a lot of TB control solutions, and we see this trend during the last years. After the pandemic, these TB incidents have still increasing, and we are really concerned about how we are going to achieve these TB targets for the NTB strategy as well. And there are a lot of more regions around the world who are still concerned about these TB incidents. So let's think about it. For example, about international regulations, we have this NTB strategy for the WHO, and I want to highlight these two pillars about integrated and patient-centered prevention care for TB people, and as well the improvement for innovation and advancing research innovation. These two pillars are really important to highlight and to reach out these targets in the NTB strategy around the world. And just to mention about during the last years, the WHO has as well endorsed about the use of AI tools as part of the TB care. So now that we have seen this introduction for the context, I'm just gonna give a brief examples about AI solutions for TB control, and maybe I want to highlight these three work areas based on computer-aided detection, as well as AI-based cough analysis and monitoring, and finally, these digital adherence technologies. I know that maybe the other speakers are going to focus more about any other work areas or many other AI solutions that we are discussing today. So just a brief introduction about the X-ray computer-aided detections. This is really important to highlight about how we have been using the X-rays during the last during many years for TB control and TB detection. So now using the AI tools is an opportunity to interpret but to detect these abnormalities in the chest X-ray for pulmonary TB. And these tools as well as has been endorsed for tuberculosis triage and screening. Not only having these AI tools like a rapid diagnostic or rapid screening test, but it's also available as a portable digital X-ray system, which can allow us to have like a lower cost for the health system, but as well really high quality images for the X-ray. And as well, these AI tools are recommended when, for example, there are not healthcare workers available in low resource settings or in any rural areas when the specialists of the radiologists are not available. So here's really important to see what is the barriers and where we are going to implement these tools to be feasible and to be acceptable for the population as well. So move on with AI analysis and monitoring. This is a really important topic. We have been working in this team in Peru because the cough is one of the main symptoms for TB, but as well of any other respiratory conditions, not only infectious diseases as well. We are talking about chronic diseases as well as asthma, COPD, as many other respiratory diseases. So cough has this overlap. It's an overlapping symptom, but can in the TB care is really important because it allows us to assess and to diagnose people who have been in treatment or people who are going to be screened or diagnosed for the disease. So even though that the cough is a really important symptom, a really common symptom for TB, it's really rare to use this cough or these symptoms as an objective measure. So that's when the AI or the deployment of new tools for cough analysis are working on. For example, there have been the deployment of questionnaire-based tools and scales, but most of these scales, for example, the visual analog scales or the Leicester-Cone square, as many others, has been based on the frequency of cough during the day, for example, but this is still subjective because it's based on the patient's perspectives. As maybe you can realize, we are not completely aware during all the day how many times we are coughing. Is it predominantly during the night or during the day? But we are not completely aware about the pattern of our cough during the day or during the week or during the month. So that's when we are going to highlight the importance of the cough analysis, of the cough monitoring, because using these AI tools, or using objective tools, can allow us to really have a good quality data, acoustic data, to improve my screening, to improve my triage, or to improve my monitoring in the TB treatment. So just to let you know about some of the areas that we have been working on the cough analysis and monitoring, there is one area about the cough detection. So what it means is these AI tools or these applications are working on to detect the cough sounds around the environment that we are and to recognize between many other sounds in the ambient. So this is about the cough detections. But we are more focused about nowadays is about the classification, the diagnosis. Is it possible to have different cough sounds, different patterns of cough sounds, and then to detect or to identify, is it based on TB? Is it based about COVID-19 on any other respiratory conditions? So this is one of the main importance about cough classifications monitoring tools. So there have been a lot of smartphone AI based after this pandemic context. They have been started to implement a smartphone cough detections because it allows us to recall the cough sounds, but as well it's a more discreet tool for the patient to just record with your smartphone. Is it available? Is user friendly usually for the patient. So it's really important to have like user-friendly tools or AI-based tools for the TB care. So some of these machine learning AI tools as well have been performed with a good high quality of sensitivity and specificity. However, one of the drawbacks about these tools is that it's needed to have like an external validation and as well larger data sets to still training the algorithm of AI. So it's just important to have this to keep in mind and to keep working on these validation stages of the tools. So now to move forward with digital advanced technologies, we have known that there are some direct observed therapy for TB, which is based on to see the patient who is taking the pills, who's taking the treatment. But most of the time, we need to think about new innovations centered in the people, centered in the communities. Is it really feasible for the patient to come back to the health centers daily to take the pills? So that's why these digital adherence technology have been deployed to ensure that to ensure the patients to have these more people-centered solutions. So with these digital tools, we can have this link between the healthcare providers and the patients and make these innovations to address these adherence patterns to the patient, but as well to see which of these patients or which of this community needs any additional assistance regarding the adherence of the treatments. There are some interventions such as the virtual directly observed therapy, as well as some SMS and electronic pill boxes as well. Just with an application or your smartphone, and it's really accessible for the people. Finally, just to mention some other innovations that is not only focused about the imaging data AI tools or acoustic AI tools or adherence treatment, but there are also AI tools focusing about the prediction and monitoring, like to predict the treatment failures or to identify any compounds to prioritize the processes for laboratory or any new innovations for TB care. So this is some advantages and challenges for the AI tools in TB care. As we can see, there's like a lot of evidence saying like, is everything accuracy, and we can just continue working on the different stages of the TB care about screening, diagnosis, treatment, as well as some prognosis or predictions in the treatment outcomes as well. It can increase the access to solutions to any low income settings or in resource limited settings as well. And it's an opportunity to integrate not only about TB care, but as well to integrate with lung health, as I have mentioned before. These AI tools sometimes have been created to classify, but not only TB, they have also include COVID-19 or influenza or any other respiratory conditions. And it's really easy to use as a point of care as well. So this is one of the advantages about this AI, but as well we need to face with new challenges with this implementation of AI tool. For example, to collect a large and high quality data sets to model to keep training the AI algorithms, and as well to have this inequality in access to technology. And another really important challenge is nowadays is that the healthcare workers can be over reliant on the AI solutions, and we can lose autonomy as a physicians to have these AI-based solutions. And there's a lot of regulations and ethical consideration as well. For example, for this acoustic AI tools, focus on the patient data privacy, if we are going to collect the records of the conversations or any privacy concerns about this AI equipment. So there are some challenges that we need to face up. And just to have like one of the last slides that I'm gonna share is, this is one of the photos of my country. For example, we can have like a really biodiversity of regions from the coast to the highlands to the rainforest, but with different challenges and barriers for the TB care. maybe the transport, maybe the access to patients to go to the healthcare centers, or maybe any rural areas where there is not, or there are really far away healthcare facilities to the patients. So these AI tools are really feasible to implement or not, and how to begin this implementation. And that's why we need to really focus about our strategies and efforts in the TB care control as a researchers, as in implementers, or as a policymakers to identify which of these areas are really the main areas to implement or to start implementations. Who are the people who really need get the access to treatment, or where are these gaps in the TB care? So this is just for last good news for my context in Peru. Since this last February, the Peruvian Ministry of Health have been delivered this AI-powered X-ray equipment to some of the high incidence areas of TB in my country, and this is a first step of implementation. But we realize that it's a really large pathway to still implementing these AI tools in the TB care. We need to still working on validation of these AI tools to prove if these are really friendly to the communities, and if the communities can really understand where they are going to use these different tools, and as well the healthcare providers. So these are some conclusions about this brief overview, and the AI-based solutions is a really significant advance in the TB care, particularly in this stages of diagnosis or treatment to address these gaps in the TB care cascade. But as well, these health innovations need to be really people-centered, need to be implemented this people-centered approach, particularly about feasibility, acceptability, and how the patients are going to understand the tools. And finally, it's really important to continue the validation of these tools. The tools are really available. We are still deploying these tools worldwide, but we need to still thinking about the implementation, the validation, and as well to put into the country's policy agendas how we are going to use it in the health systems in the real setting. So this is just some conclusions, and thank you so much for your attention.
Thank you so much, Dr. Patricia, for that amazing presentation, and especially for your emphasis on how we can apply AI methodologies to meet those resource gaps in the TB crisis. So now we'll move on to our next speaker. Sorry, I'm just sharing my slide. All right. We're going to move on to our next speaker, who is Dr. Yahya Tayalati. Dr. Yahya is an expert in experimental high-energy physics, having worked for over 20 years in major physics research collaborations such as the Antares collaboration and the Atlas collaboration for the detection of and measurement of high-energy atmospheric particles. Dr. Yahya is also the director of AI4PEP Morocco, which is a research network focused on leveraging the potential of AI techniques to improve early TB detection, drug resistance predictions, and monitoring of new bacterial strains in tuberculosis. Dr. Yahya, over to you.
Hi, good morning. Good afternoon. Do you hear me?
Yes, we can hear you.
Can you see my slide?
Yep, yes, we can see your slide.
Okay, perfect. So I'm Professor Yahya Tayalati from the University Mohammed V in Rabat. And I'm honored to present to you today this our project AI4TB, which is a Pan-African artificial intelligence initiative to fight TB in Africa, with particular focus on Morocco, Burkina Faso, and the Democratic Republic of Congo, with, of course, the support of the AI4PEP initiative. And before to start, let me please to thank the organizer of this important event, especially Professor Jude from York University, Emmanuel, and also to recognize and special gratitude to the Canadian IRDC. So, as you heard from my colleague Patricia, TB continue to be one of the deadliest infection disease worldwide. You have seen that with my colleague. Just in 2022 alone, we have over than 10 million people were affected. In particular, Africa bears a disproportionate share with more than, you can see, 80% of the TB cases in the global south. You have some statistic here, more than 3,000 cases, new cases in Morocco, similar amount in Burkina Faso, and it's even worse in the Democratic Republic of Congo. You can see we have more than 300,000 cases each year, and the Republic Democratic of Congo is among the top 15 countries worldwide. What is also very alarming is the fact that we have continuously a rise in drug resistance. So this makes it very difficult to treat TB, and our conventional and classical diagnostic method are all the time, especially in African and underdeveloped country, very slow techniques, manual and heavily dependent on human expertise, which is simply not enough. So why we have a big opportunity with artificial intelligence? For the case of African country, TB is largely diagnosed through manual microscopy and chest radiography. So as I mentioned, these techniques are slow, time consuming, and we have a lack of reproducibility and depends, of course, on scarce human expertise, which are rare on some African countries, like, or we don't have enough expertise, like radiologists or trained technicians. So artificial intelligence brings us speed. We are more fast to detect, scalability and consistency with IA. So I think we have a real opportunity to address local healthcare bottlenecks in order to modernize diagnostics, reduce diagnostic delay, and improve access, especially in remote area and undeveloped area in African countries. So that's the idea behind the AI4TB consortium. So this is the state that are participating to this project. So it's strong, I would say, multidisciplinary and truly Pan-African consortium. It brings together IA experts from Morocco. Morocco is represented, by the way, by many universities. My university in Rabat, University Mohammed III, University Mohammed VI, and the Knesset. You will hear in a while my colleague Zibri from Knesset. And we have also experts from the RDC, Republic Democratic of Congo, and also from Burkina Faso. You will hear a presentation from my colleague Tani in a while, and she will present the situation in Burkina Faso. And we collaborate with colleague from South Africa, with particularly with Professor Bruce Milado, and we have also a collaborator from Qatar. So this effort is backed by AI4PEP and global AI for Health network that are pushing for local, ethical, and effective AI solutions. So let me now present the vision of the consortium. So our vision is very clear. The goal is to harness the power of artificial intelligence to improve TB detections and also to guide the treatment. And one important aspect we want to reach is to monitor the speed of TB in real time. And especially we are working to predict clinical outcomes using artificial intelligence model trained on patient data. We would like to develop AI tools to interpret, as presented by my colleague Patricia, X-ray imaging, but in accurate way. And we, as I highlighted earlier in this presentation, we want to anticipate the drug-resistant TB, which is becoming a serious and alarming issue with TB. And finally, we want, of course, to monitor the transmission of TB across regions. So this is a really strategic response to a problem that demand new thinking. So in this slide, you can see some goals. You will hear in a while from my colleague Zebri about our work in genomics, and I will focus here on and the detection of TB with microscopy. So we have introduced the AI in microscopic innovation in order to speed up the detection of TB. But we have also works on genomics, on monitorings that are owing. So in particular, when you want to detect the TB, usually the technician need to review 100 of images per patient, which is exhausting and could induce errors. For this particular case, as an example, we are developing modular hardware and artificial intelligence system to automate image capture and bacilli detections. So this is the image that the technician classically analyzing, which is really time consuming. So with artificial intelligence, we have a huge opportunity to do the same work in rapidly, in fast way, in less time, and in efficiently. And as you know, when we detect TB in early stages, this makes the chance to treat very high. So the manual counting of bacilli in microscopic slide is not just tedious, but it's slow. It's also highly subjective. So our solution is an IA powered system that analyze these images quickly and accurately, providing objective, reproducible results. So this is one of the examples that we have witnessed the AI4TB project. First prototype is already has been already tested, and my colleague in the consortium are improving these tools. So on this slide, I will show the platform that we are developing. So this platform will combine multiple modules. Here are shown 3 modules. As it is done in Peru, we would like to explore AI for chest X-ray diagnosis. We also target microscopy image interpretations. And an important work is ongoing, which concern the drug resistance. And we leverage AI for genomic studies. And like my colleague in Peru, we have started some works on the cough, which could be a strong indication of TB. Of course, there are many challenges with these projects, as with any ambitious projects. We face real challenges, sometimes technical challenges related to the lack of annotated local data. So our colleagues are working on that in order to have the data, real data in the 3 countries. And of course, we need for AI, we need the interpretation, medical interpretation of these data in order to explore them with our AI model. We must build cloud infrastructures in region with limited connectivity. You are aware that in Africa, infrastructures and connection to the bandwidth are major issues, especially in remote area. And one big issue is that we have to, and we must train new generations that are familiar with artificial intelligence. With my colleague Mzibri, we have contacted our stakeholders, and we bring their attention to the importance of including IA in the TB fighting strategy. It's difficult because we need to train new generation of clinicians, new generation of technicians that will do the job in situ. And to be honest, IA4TB and IA4PEP, it's not only challenges, but it's very high opportunity. So with the help of the Canadian IRDC and with the help of our colleague from York University and the IA4PEP network in general, I can see enormous opportunity, like to create an open data set in Africa, and to expand all the tools that we are developing here in the IA4PEP, or maybe our colleague in Peru and so on. All this technique can be used in different areas to fight, for example, disease like HIV and all kind of antimicrobial resistance. And the important thing also is to for us, for these 3 countries, Morocco, RDC, and Burkina, is we have this big opportunity to position Africa as a leader in AI for health, which is, I think, an important aspect. So all this, of course, should be done under the IA4PEP umbrella. So IA4TB is not just a technical project, but it's also a political and social one. And the important things, it's aligned perfectly with the goals of IA4PEP. with the goal of promoting equity in public health, building local research capacity, and grounding policy in solid data. So our tools and the tools that are developed are being designed with this sustainability spirit in mind, so that they can continue serving community long after the push, after the official end of the project. So what next? Huh? So we would like to in a couple of months we will provide and we will launch. It's in progress, of course, but we will launch very soon a minimal version of the platform that include, in automated way, the possibility for the public to analyze the chest images, cough, and to also do some genomics prediction on drug resistance. And so we plan to release open source model trained on African data. And as I mentioned earlier, it's important to train people. So we plan to organize workshops to connect TB professionals with AI researchers and with clinicians. So as you can see, this is just the beginning. And we believe that AI4TB can become a model for health innovation in Africa, by Africa, and for Africa. So thank you for your attention, and thanks to all our partners, collaborators, and institutions who are helping make these visions a reality. I think together we can make free world from TB with 21st century tools and with artificial intelligence techniques. Thanks a lot.
Thank you so much, Dr. Yaya, for your excellent presentation and for the emphasis on how we can connect and collaborate across regions through AI for TB and other initiatives toward fighting TB from all angles and in a collaborative way. So our next speaker is Dr. Hasiru bin Hashim, representing the Federal Territory State Health Department of Kuala Lumpur and Putrajaya in Malaysia. Dr. Hasiru is a medical expert in internal medicine with training from Malaysia, Edinburgh, and Harvard. As Assistant Director of the Federal Territory State Health Department in Kuala Lumpur and Putrajaya, he spearheads healthcare initiatives such as the Digital Healthcare System Tuberculosis Watch, adapting free healthcare platforms with natural language, coding, and machine learning. Dr. Hasiru, over to you.
Hello, everyone. Can everyone hear me? Am I audible?
Yes.
Okay, great. So, hi everyone. Good morning, good afternoon, good evening, wherever you are in the world. Okay, my name is Sashiro. Uh, Thank you so much for the invite, for the organization, for the community, for the committee to come up with this and hosting this particular event on TB, World TB Day. Um, I've kind of anticipated that the first two speakers will talk about more in the introduction part of the tuberculosis, how the disease spreads, and what is TB. So I'll jumpstart my discussion or presentation on the applied cases for AI, since we're talking about uh, application and TB specific AI used. So Malaysia is a small country just above Singapore. If you're not familiar with it, we are in the
in the region in the Southeast Asia, and we are still in the midst of a status of developing country. And moreover, it is quite the same as any other developing countries for that matter in terms of TB. In fact, the cases has been increasing in trend, and we are back into well, the 100 over incidence rate, which means we are the high burden country of TB as of last year. So it's not a good thing, but we are making amends for that. In terms of TB, I would like to emphasize that and echo that for the previous speakers like Dr. Patricia and Dr. Sergi and the others on past events. Congratulations, because you have been instrumental in terms of developing AI related applications for TB or lung disease specific for detection. And overall, in terms of AI, it is one of the things that updates and essentially escalates our senses in terms of our vision, the way we hear things in terms of audio, in terms of analytics, and even pathology in terms of digital pathology. Quite impressive with the Moroccan speaker just now in terms of detecting the bacilli using a smartphone. Just bravo. So for Malaysia, I've been started off with a 4-year project that has been quite impactful in terms of our state level. So we use AI, and in terms of AI, I love going back to the basic, right? The basic says that we find, we treat, and we prevent. So that's the mantra of treatment of TB, and that's how we end TB, right? We find those who are have this disease. We find this indexes, this contacts, and we treat them all with respects to their symptoms, their risk factors, and we prevent them from ever getting TB again, and controlling that in terms of public health. But to do that, also we have to undermine the essentials of adherence, because it's an it's a long way to get one who is having TB and getting them cured. We are talking about at least 6 months worth of antibiotics. The antibiotics is not just one or two, but a minimum of four, uh, and it comes with side effects as well. So it's not a good it's not a good palatable medication to be on. But yeah, there are challenges, and it needs a lot of motivation from the patient themselves. So a lot of defaulting occurs in terms of TB, and not just TB, but any chronic disease such as hypertension, diabetes, any metabolic disease, even heart diseases that are on long treatment. So we are talking with TB, an ancient disease that we have identified a treatment, but the duration haven't changed much in the past decade. It has been for 6 months. There's a BPAM regime cut in terms of 4 months. Still, 4 months is still a long time to commit. So we made a system and a digital system that not only, because monitoring is a hassle, right? In terms of whether it's developing countries, even if it's a developed countries, monitoring is always a hassle. We are not talking about 10 or 15 patients. We're talking about hundreds of patients, and it get worse even with our population set. So monitoring is being done, but the active intervention is the one that lacks in terms of the discussion there. So what we set about to find out and to intervene is that it's not just the monitoring aspect, but the defaulting aspect, right? So whenever a patient defaults, whether it's within a physical TCA, physical medical appointments, or a virtual medical appointment, or even at home, where they stop taking the medication at home, or forgets it. So that essential of defaulting, that that issue, we need to identify, and we need to escalate and prioritize uh, the mitigation in terms of the intervention. We are talking about immediate intervention, because within 2 weeks, if one were not to take medication within 2 weeks, they are bound to restart the whole treatment from scratch, from day zero. So it's not a motivating start for that matter. And if you do take medication on and off, you will likely to get patient will like to get resistant, and that once is partly of the escalating part of the the resistant cases amongst third world population. So that's a worry. So we have two identity, right? The indexes and the context. Index cases, we know how to treat. We know that the drug regimen, we can treat them. But in terms of context case of the index cases, right? So we need to find at least 10 contact cases as endorsed by the WHO. So we need to find at least 10 contacts for every single index patient. So that's a problem with our staff as well, because in any organization we are limited to time, we are limited to applications, sets, even staff. So it is a widespread problem. So the application or the system that we made is very simple, very straightforward, and it relays any absent events for immediate intervention. So that's it. So it relays any absentees, it relays any non-adherent, even at home, for the health facility or the health staff to come in to intervene. So the intervention, right, comes into an escalator or spectrum of triad or things that to be done. It can be as simple as calling on phone and reminding the patient, hey, you need to come to the clinic today, or you have appointment today, or we can, if you're busy, we can reschedule for the appointment, or just have a call to remind them, hey, take your medication today, because it is important. And that's the simple one, right? That's the simple intervention. It can goes up, it can escalate up to a more serious intervention, such as a health inspector driving all the way to your house, knocking on your door, and to give a notice of intervention. It may be a court order for that matter, because certain countries in Asia practices very strict regulation in terms of compliance. And in terms, what I've identified is that Malaysia is one of them, and another two is China and also Singapore. And that may be an underestimate, because whenever a pandemic hits, like the previous one, COVID-19, law enforcement has been will spread, right? Any adherence, not adherence, non-compliance, or any the intervention can be clinical, can be public health, and it can be both in terms of uh,
Sorry to
law and order, right?
uh, sorry to interrupt, Dr. Hasiru. We just wanted to confirm if you have multiple slides or just one slide to share, because we're
Oh
only
yeah,
seeing
we have.
the. Okay.
I have a multiple slide, but
Oh,
the explanation, I'm getting to the explanation there. So,
sorry. Go
but thanks
ahead.
for yeah, thanks Taylor for the heads up. So the technology that we adapt is one is to relay any absent events, but to do that, we have to intervene a lot of things, and we are not coming into AI just yet. We're coming into the vision aspect, the real time relay, the predictive analytics in terms of machine learning, and even the collaborative response. Back to basics, right? We have to intervene. We have to treat our patient, identify our patients, treat them, and prevent from TB. So that's the hallmark. That's the mantra of it all. So the collaborative response, you can AI and automate the whole process. But in terms of reality, the third world country or the developing country may need AI more than ever, and it will be very, very expensive. In terms, before we realize the importance of AI, then the machine learning kicks in, the automation kicks in, and we leverages on even free platform, open source platform that can collaborate in terms of inter-organization collaborative response and to coordinate an intervention. I love examples, right? So I can give you for example. So if I were a TB patient and I would not to come to clinics today, so my name and my details will get relayed to the system, right? And the system does not intervene with any existing system. So that's funny in a way because we always talk a centralized system that integrates and communicate with a lot of any of other organization and health systems. But in terms of, with a jungle of different platform that does not communicate with other, it will get a lot of time to get centralized. So in terms, we adapted a modular approach where we give a plug and play system so that the private setting can use them, the rural and urban setting can use them, academia can use them. So any healthcare facility that even have or even lacks any technological experience but have access to the internet can use the system to relay any absentees. So when my name is pinned there or flagged when not I'm not attending my treatment or my um, my medication days, right? So an intervention will be set there and it will escalate up to the point where police report can be done or even migration or the transport services can be notified. So intercollaboration is there. But you see, the whole system is based on not trusting our patients, right? So which is a little bummer, but because we need to trust patients, we need to give incentivize our patient to get them acquaintance and increase their effectiveness of the treatment. So to do that, we give an extra spice of collaborative expand in terms of NGO. So there's a lot of why our patients are not coming and not committing themselves to the days at the clinics or not taking their medication as prescribed. And most of them need NGO intervention, such as transport, such as financial aid, and even both for that matter, because there are cases of genuine problematic and in need of moral support, financial support, and even transport support. So that's one of the area of ways where we can nullify and gather all this information and bring it into a collaborative response and driving it into a machine learning process, right? So when the where is the AI coming? So we adapted a natural language syntax within an intervention so that when any description of a problematic cases, so it will transcribe that into what sort of problem it is, classify that, and put into a predictive model whether how we can address this patient and how risky is this patient to be non-compliant in the future. So we are predicting not just the intervention part, but also we are predicting the measures of when how is will a patient be defaulting in the future. So that's what we are set for this particular area of intervention and our project. And in terms of what we achieved for the past four years was an increase of KPI and cut back a reducing rate of defaulting up to 40% in terms of our state level. This is what I've told you about the events of defaulting and why the patients are not taking the medications. So the main challenges is in terms of the TB treatment themselves. So I'm going to relay to you a presentation here that depicts a few graphs for visual aspect. We can see between the system approach, there is a marked increase in defaulting rate and in decrease in KPI in terms of curing rates. And the table flips over after we done the intervention. So of course there's a lot of machine learning, but there's a lot of coordination as well, not just in terms of AI. In terms of KPI, we are not focused on in terms of only the nationals, but also any other patients for that matter, even the non-nationals, even the cases of that WHO have not flagged it for monitoring. That includes the previously failed cases, the defaulted cases, and even the resistant cases. So this is very, very important, right? So I'll end my presentation today with a very, very nudge aspect in terms of not just AI, but in terms of the overall aspect of the basic clinical approach that we need to treat our index case. We need to treat our contact cases, and we need to exemplify the compliance aspect to get our patient cured. So if any other comments or question, please bring it up so I can help you and assist you in terms of answering them. Thank you so much for your time.
Thank you so much, Dr. Hasiru, for that excellent presentation and the emphasis on how we can sort of address these patient adherence questions in a way that's responsive with AI technology. Excellent presentation. So we're going to switch to our fourth presenter now. Sorry, let me just share my screen. Great. So our fourth panelist is Dr. Tani Sagna from Burkina Faso. Dr. Tani is a researcher at the Institut de Recherche en Sciences, sorry for my French pronunciation, but the Institut de Recherche en Sciences de la Santé of the Centre National de la Recherche Scientifique et Technologique of Burkina Faso, among other prestigious research affiliations. Dr. Tani has advanced expertise in epidemiology, biotechnology, and biochemistry, and her career focuses on improving people's health through the research into the genetic causes of diseases. She is building a national and international reputation in the field of HIV/AIDS, tuberculosis, and other respiratory infections, genetic cancer, and other epidemic-prone diseases that involve genetic predisposition. She is also the winner of the 2024 Burkina Faso Special Prize for Excellence in Scientific Research in the Women Health Sciences category. Dr. Tani, over to you. Hello, Dr. Tani. Are we unable to hear you?
He probably has some connection difficulty. Can we proceed and come back to Dr. Sanya later?
Sure, we can proceed. So our present.
Can you hear me now?
Oh yes, we can hear you. Great.
Okay. Thank you. Sorry.
No worries. Thank you.
And okay, the presentation. Do you see the presentation?
Yes, we can see it.
Okay, thank you. So the theme I want to present you is about the prevalence of tuberculosis and evolution of diagnostic method in Burkina Faso from 2015 to 2024. So we are going to focus on pulmonary tuberculosis. I will skip most of the generalities because my colleague already talked about this. But let's remind that preventing tuberculosis involves screening, treating affected individual to prevent the spread of the disease. Vaccination with BCG is used in many countries to prevent a severe form of tuberculosis in children. Infection control measures, particularly in healthcare setting, are crucial to prevent the spread of the disease. Exposure to Mycobacterium tuberculosis often lead to the development of latent tuberculosis infection with 19% probability and 5 to 10% lifetime risk of progression to active tuberculosis, which occur mainly in the first 2 years after infection. So in Burkina Faso, despite the implementation of national control and prevention strategies, tuberculosis transmission remain high with an incidence of 44 cases per 100,000 inhabitants in 2023. In order to reduce the incidence of tuberculosis, do you see my screen?
Yes, we see your screen. It's not in presenter mode, however. If you want to share the full slide.
Hello?
But we can see your screen.
Okay. Thank you. So in order to reduce the incidence of tuberculosis from and to reduce the mortality rate by the end of 2026, a number of actions are being carried out, like active case finding, access to diagnosis, access to treatment, and access to tuberculosis follow-up. However, today, despite tens of thousands of research studies and clinical trials, early, rapid, and accurate diagnosis of a different type of tuberculosis remain a major challenge for tuberculosis control. So we have a lot of methods already cited by my co-panelist. But in Burkina Faso, molecular biology test coverage has increased over the years, following the increase in the number of gene expert machines and the reduction of the number of eligibility criteria. The gene expert was mainly used for the resistance profile and was reserved for the retreatment cases. It was extended to some new cases in 2015. The target was subject at risk, including children, the elderly people living with HIV, and prisoners. Since 2019, the expert test has been performed as a first-line test for all suspected cases of tuberculosis, but in laboratories equipped with a GenExpress device. When the laboratory does not have a GenExpress device, the test is performed for microscopy positive tuberculosis case and in the subject of at high risk of TB. So in conclusion, as for diagnostic methods, it is therefore necessary to develop new, effective, and accessible diagnostic tools to improve tuberculosis surveillance, and why not to achieve the end TB objective. Let's take a look at artificial intelligence tools. We are now in the consortium of AI4PEP by Morocco team. Thank you, as announced by Professor Tayatali. Thank you for your attention.
Thank you, Dr. Sagna, for that great presentation and for the emphasis on how we can apply AI for TB surveillance and revolutionize this challenge. So on to our final speaker for today. Our fifth panelist is Dr. Mohammed El-Zibri from Senestan, or the National Center for Energy Sciences and Nuclear Techniques in Morocco. Dr. Mohammed is the head of the Life Science Division at Senestan and has been working there for over 25 years, coordinating many national and international research projects on cancer and infectious diseases, mainly tuberculosis. Dr. Mohammed has published over 200 international publications, 2 books, and several chapters, and has supervised many master's and PhD students. Dr. Mohammed, over to you.
Thank you very much. So you are hearing me now?
Yes.
Perfect. So I would like first to thank all the organizers for this nice meeting. And I would like also to apologize because I will give my talk on French because I didn't have enough time to prepare my talk in English. So, but some slides, or many slides, are in English. And if there is need, I will translate. So, pour moi, ça va être le plaisir de vous présenter donc les derniers, enfin les data en relation avec la tuberculose. Et je vais aborder un aspect qui nous paraît très important, qui est le génotypage moléculaire des souches, et sur tout le travail qui a été réalisé, qui nous a permis de disposer d'une base de données qui pourra être exploitée justement pour tout ce qui est intelligence artificielle et comment prévenir l'évolution des souches mycobactériennes en circulation au Maroc. Alors, un petit rappel est pour dire que, comme vous le savez, la tuberculose est une maladie pulmonaire infectieuse dont l'agent causal est le Mycobacterium tuberculosis, et à travers le monde, donc le tiers de la population est infectée, avec environ 9 millions de nouveaux cas recensés chaque année. Au Maroc, le nombre de cas notifiés, ça a varié entre les 30 et quelques mille jusqu'aux 29 000 par an, donc ça reste relativement stable, avec un taux de notification entre 90 et 80 pour 100 000 habitants. Les dernières données publiées et qui remontent à, donc c'est des données de 2023, publiées en 2024, ont fait état de 35 000 nouveaux cas de tuberculose, toutes formes confondues, 92 nouveaux cas et 5 décès par 100 000 habitants. Ça touche plus les hommes que les femmes. Et la distribution à travers le pays montre qu'il y a des zones, on va dire, enfin, ce sont des zones de hotspot, enfin, des points chauds, principalement donc le nord de la région de Tanger, la région de Rabat Salé, c'est la capitale, et la région du Grand Casablanca, c'est la capitale économique.
Sorry, to disturb you. Can you go to full screen? Affichage complet. Sorry.
C'est bon? Alors, donc, la région du Nord, la région de Rabat, qui est la capitale, la région du Casablanca, qui est la capitale économique. Et ainsi, avec ces 3 régions, nous avons, ça représente 65% des cas enregistrés. Alors, qu'en est-il dans la situation au niveau national? Au Maroc, on a renforcé la détection des cas, ce qui explique l'augmentation des nombres de cas notifiés, et on a réalisé une progression importante en termes de taux de succès thérapeutique qui avoisine le plus de 90%, et qui s'inscrit dans l'objectif de l'État en matière de prise en charge de la tuberculose et qui dans le cadre du plan stratégique national. Alors en effet, donc les cas notifiés sont mis sous traitement rapidement et gratuitement dans le cadre de ce plan. Et malheureusement, ben, les cas les plus exposés, ça reste toujours la population active entre 15 et 45 ans. Au cours de ces 2 dernières années, on a lancé un programme de e-learning au profit de 2500 professionnels pour justement renforcer les compétences en matière de prise en charge TB. Et on a également mis en place un plan 2024-2030 qui repose sur le renforcement de la dite riposte, mais également la mise en place d'un projet fédérateur qui implique différents départements ministériels et qui permettra donc d'améliorer les déterminants socio-économiques de la maladie. Et comme vous le savez, la TB est une maladie dite des pauvres, et du coup, il y a plein d'autres facteurs qui rentrent en jeu au-delà de l'infection par la bactérie. Il reste encore des défis importants qui doivent être soulevés. C'est surtout cette baisse annuelle de l'incidence qui reste insuffisante, l'action sur les déterminants socio-économiques qui doit être formalisée dans un cadre de responsabilisation. Et
sorry,
le
doctor.
plus... sorry
to interrupt. Are you able to share your slide in presentation mode? Like as in a full screen mode? Because right now we see it in a smaller mode.
But when I go to the panorama, is it okay now?
If not, no, you can revert back to sharing the screen. It's okay.
Okay, perfect. So, le plus grand...
Sorry, but we can't see the screen now. Can you share screen again? Sorry, but can you share the screen again? We're unable to see the screen.
Well, I'm going to.
Thank you.
It's okay now.
Yes, thank you so much.
Le grand problème au niveau national, c'est la résistance et surtout la multirésistance. Et les dernières datas font état de 1,5% chez les nouveaux cas et 12% chez les cas retraités. Et nous n'avons pas de données réelles sur les cas extrêmement résistants qu'on appelle les XDR. Alors, un petit rappel, quand on parle de résistance, il y a deux types de résistance. Il y a la résistance acquise, la résistance primaire. Acquise, c'est quand une personne infectée par TB arrive à se débarrasser de tous les cas sensibles, mais il y a émergence d'un clone qui est résistant et qui va se propager dans les poumons, et on parle de résistance acquise. Quand cette personne infecte d'autres personnes, on aura à ce moment-là une résistance primaire. Au Maroc, le traitement de la tuberculose, comme préconisé par l'OMS, repose sur un traitement des antibiotiques de première ligne, isoniazide, rifampicine, pyrazinamide, ethambutol et streptomycine, et également des antibiotiques de deuxième ligne, fluoroquinolones, injectables, les polypeptides, et ainsi de suite, avec une efficacité qui diminue, mais surtout la toxicité qui augmente. Pour le traitement préconisé par l'OMS pour la tuberculose sensible résistante est également le cas de tuberculose infection. Donc, on a les différents traitements qui sont disponibles et qui sont gratuits et qui sont répartis en 5 groupes. Le groupe de première intention, les injectables, les fluoroquinolones, les médicaments, les bactériostatiques, et enfin un groupe qui est réservé uniquement aux cas qui sont pharmacorésistants. Et bien entendu, avec l'efficacité qui diminue et la toxicité qui augmente quand on part du groupe 1 au groupe 5. Alors, le problème de la tuberculose, MDR, plutôt résistante, c'est que ça va d'une simple résistance vers des résistances multiples. Et là, on a classé la résistance en fonction de nombre de types de résistance. Nous avons la TB MDR, c'est toute TB résistance à l'isoniazide plus la rifampicine, peu importe s'il y a une autre résistance ou pas. Et puis vous avez la XDR qui est une résistance, c'est une MDR avec une résistance à un fluoroquinolone et également à un antibiotique injectable. Et entre les deux, vous avez la pré-XDR, quand on a une MDR avec une résistance à une fluoroquinolone ou un des antibacillaires injectables. Et la forme la plus grave, c'est la TDR, qui est la résistance à tous les antibacillaires. La résistance aux antibacillaires est souvent due à des mutations au niveau de certains gènes. Pour la streptomycine, c'est au niveau du gène RPSL-RS. Pour la rifampicine, c'est surtout le gène RPOB. Pour les isoniazides, c'est plus complexe parce qu'il y a beaucoup de gènes qui peuvent conférer la résistance. Ben, pour chaque antibiotique, il y a un gène associé qui est souvent la cible de l'antibacillaire. Alors, en se basant sur ça, on s'est dit qu'on va quand même faire une étude pour essayer de brosser une image assez exhaustive donc des différentes mutations génétiques qui provoquent la résistance aux antibacillaires. Et on a commencé, les techniques que nous avons utilisées, d'abord la dot blot hybridation avec un dot blotter qui permet de déterminer si la souche est sensible ou résistante et déterminer également surtout le point de mutation qui confère la résistance. Également, on a travaillé avec le séquençage et les techniques commerciales légères, GenExpert et le Hein test. Sur une collection de rabats, on a pu montrer les principales mutations qui confèrent la résistance au niveau du gène RPOB pour la rifampicine, 4G1HA pour les isoniazides, RPSLRS pour les streptomycines et l'éthambutol B pour EMB pour l'éthambutol. Et là, on a pu quand même avoir une idée sur les mutations qui confèrent la résistance. Sur une collection de souches de Casablanca, on a également mis en évidence l'ensemble des mutations génétiques qui confèrent la résistance aux antibacillaires de première intention, RPOB, rifampicine et isoniazide. Nous avons également travaillé sur les souches de Casablanca et pareil, on a mis en évidence, cette fois-ci par le Hein test, les mutations qui vont conférer la résistance. Et si vous remarquez, on a travaillé sur les souches de Rabat, de Casablanca et de Tanger, qui sont les 3 hotspots de la tuberculose au niveau national. En l'absence de data sur les XDR, on s'est dit on va quand même, sur notre collection, regarder les mutations qui confèrent la résistance aux antibacillaires de deuxième intention. Et on a recherché les mutations dans GIR-A et GIR-B pour la résistance aux fluoroquinolones, dans les gènes RS, LI-AIES, tout ce qui est résistance aux injectables. Sur la collection de Rabat, on a pu montrer que les mutations portent principalement au niveau des codons 90 et 94, au niveau de GIR-A, avec des polymorphismes qui ne sont pas associés à la résistance, mais il n'y a pas de mutation dans GIR-B. Et on n'a pas trouvé de mutation dans le gène RS, donc on n'a pas de XDR, mais plutôt des pré-XDR. Et c'est plus de 25% de cas qui sont quand même pré-XDR. Sur la collection de Casablanca, pareil, on a les mutations au niveau des codons 90-94 avec les polymorphismes, mais pas de mutation dans le gène GIR-B, donc il y a uniquement le gène GIR-A. Pareil, une mutation silencieuse dans ERS, donc pas de mutation dans le EIS, dans le TLA. Donc finalement, pareil, on n'a que des pré-XDR à cette époque-là. Donc, on a quand même pas mal de mutations identifiées et on a une idée assez claire du type de mutation qui confère la résistance dans les souches bactériennes en circulation au Maroc. Sur cette base, on a proposé un algorithme qui permet de placer l'approche moléculaire au cœur de la prise en charge de la tuberculose et qui permet de s'affranchir de la lourdeur des tests conventionnels pour essayer d'apporter une réponse rapide en termes de résistance et une prise en charge surtout rapide des cas qui portent la résistance et éviter la dissémination des souches. Alors, un autre volet qui nous paraît important aussi, c'est l'épidémiologie moléculaire. Et surtout que chaque fois qu'on parle d'épidémiologie, les gens s'intéressent au nombre de cas recensés, au nombre de cas reportés à travers les laboratoires Sentinelle. On s'est dit, on va essayer quand même de voir, en termes d'épidémiologie moléculaire, quelles sont les souches qui circulent au niveau national. Et cette caractérisation de souches, ou des génotypes de souches permettrait de comprendre la dynamique de transmission de la tuberculose et également voir s'il y a des associations entre la résistance et les souches en circulation. Les techniques les plus utilisées, c'est la RFLP qui se base sur les séquences d'insertion IS, le spoligotyping qui repose sur les direct repeats et les MERU-20R qui utilisent des mini-satellites. Alors, Pour la RFLP, ben, il est très lourd parce qu'il faut récupérer l'ADN de la bactérie, faire une gestion, faire des hybridations et après sur des films, la lecture, bon, c'est très laborieux et très lourd. Mais en échange, nous avons des techniques qui sont commercialisées, qui permettent d'avoir des résultats aussi importants. Et en l'occurrence, le polygotyping qui repose sur les DR. Et là, avec les DR, il suffit de faire une PCR dont les primers sont dans les DR pour amplifier le spacer. Ce spacer-là, qui peut se perdre, et donc ça permet bon, il y en a 43, ça permet d'avoir une idée sur le type de souche. Donc on amplifie le spacer, on hybride avec des sondes dans les spacers, et ça nous permet d'avoir des résultats dans un autofilm comme celui-là. Et on va voir comment on va faire la lecture. Pour les mérus, il y a des mini-satellites un peu partout. Donc, le nombre de mini-satellites par méru permet de renseigner sur la souche. Donc, par exemple, si je prends le A, il y a 5 mini-satellites, mais il peut y avoir 6 ou 7 ou 3 ou 4. Et en fonction de la taille de la PCR, on va déterminer le nombre de mini-satellites. Et avec le nombre de mini-satellites, on va générer un code qui va être utilisé pour l'exploitation des données. Donc, une petite comparaison entre les techniques utilisées dans l'épidémiologie moléculaire, on voit bien que l'IS, c'est la gold standard et elle est très laborieuse et très lente. Et en parallèle, nous avons ce polygotyping et MERU qui peuvent être utilisés directement dans les crachats, ou les lysats bactériens. Le polygotyping qui peut être digitalisé et la MERU qui peut également être utilisée avec un flux important. L'exemple que nous avons ici, voilà un autofilm que nous avons obtenu qui nous permet, donc voilà, on va prendre une ligne, ça correspond à une souche, et donc avec un code binaire, la présence de la bande c'est 1, l'absence c'est 0, ça nous permet d'avoir un chiffre à 43, et après on va essayer de les grouper en 3, et chaque 3 correspond à un code, donc ça nous permet de générer un code octal. Ce code octal sera introduit dans la base de données, internationale, et ça permet de déterminer le type de souche en circulation. Donc, dans cette étude, on a pu montrer qu'il y a une diversité importante, mais que ça reste quand même homogène. Homogène parce qu'il n'y a que 3 familles de mycobactéries. L'âme, le claté et la famille Harlem, avec des profils majoritaires qui sont les sites 42, 50 et 53, et nous avons pu quand même enrichir la base de données avec 7 nouveaux sites. Quand on a comparé avec le profil de résistance, on a montré que finalement, dans les souches sensibles, nous avons principalement des lames de Harlem et T. Pareil pour les souches MDR. Par contre, pour les souches pré-XDR, c'est surtout des Harlem. Et ça, ça permet de dire qu'il y a l'émergence de clones qui vont essayer, qui sont associés donc à la résistance aux antibiotiques de deuxième intention. Pour les mérus, on a trouvé quand même qu'il y avait un mythe abondant qui est dominant, c'est le mythe 43, et toujours les mêmes souches, les mêmes familles, Lam, Harlem et T. Alors, on a fait une étude comparative pour voir l'évolution des souches, et on a trouvé qu'avec le polygotyping, nous avons un taux de regroupement qui reste comme stable, mais par contre avec les mérus, on a un regroupement qui diminue. Le taux de transmission avec le polygo reste stable, mais avec les mérus, il diminue. Il diminue parce qu'il y a l'évolution des souches, mais il diminue parce qu'on a utilisé le format 24 qui est plus discriminant et avec une détermination un éclatement des types plus important. Quand on a comparé entre résistance et épidémiologie, on n'a pas trouvé d'association entre les profils de résistance et les profils épidémiologiques, sauf pour les mutants GIR1 qui appartiennent pratiquement tous à la famille LAM. Et donc, il y a probablement un clone spécifique qui est en train d'émerger et qui serait probablement associée à cette résistance aux antibacillaires de deuxième génération. Je finirai par remercier tous les collaborateurs au niveau national et international et je vous remercie pour votre attention.
Thank you, Dr. Mzibri, for that presentation summarizing the genetics of TB and its resistance. So with that, that is all of our panelists' presentation so far. I'm going to quickly transition to a synthesis of the talks and what we've learned today from them. But I'm just pasting an English summary of Dr. Mzibri's conversation in the chat for those who need a translation. Let me just share my slide. All right. So moving on to the synthesis. So thank you so much again to all of our amazing panelists for their excellent presentations. It was great hearing you today. I'm just going to give a brief synthesis of this event, and then we're going to transition to the Q&A. So first of all, we heard from Dr. Patricia Espinosa Lopez from AI4PEP Peru, who dove into the different types of existing AI-based methodologies for TB control. Specifically, she went into chest X-ray computer-aided detection, AI-based cough analysis, and digital adherence technologies. Then we heard from Dr. Yaya Tayalati from AI4PEP Morocco, who emphasized how AI can revolutionize TB diagnosis in African countries by substituting the slow, manual, and time-consuming techniques with speedier and more scalable diagnostic solutions. Then we heard from Dr. Hasirul bin Hashim from Malaysia, who shared how the virtual healthcare platform TB Watch is helping to advance TB treatment adherence among patients in Malaysia, tackling the crucial TB treatment success challenge of patient loss to follow-up. And then we heard from Dr. Tani Sagna from Burkina Faso, who gave an overview of the evolution of tuberculosis landscape in Burkina Faso within the past decade. And she emphasized the potential for AI to fill in a key resource gap, which is the need for effective and accessible diagnostic tools for improved TB surveillance. Lastly, we just heard from Dr. Mohammed El Mzibri from Senestan in Morocco, who shared the epidemiological context of tuberculosis in Morocco, discussed the genetics of TB disease, and dove into the science underlying concerns around development of ultra-resistant TB. So as we've heard from our panelists today, the challenge of ending TB is evidently very multifaceted, and it intersects not only the science behind the disease prevention and treatment, but also the social determinants and resource equity factors that influence availability of effective tools for tackling the disease in regions with these outbreaks. So this important conversation emphasizes the need for AI tools in problem solving to end TB, and it invites us to think about how we can revolutionize TB treatment delivery and disease surveillance in the global south and the entire world. This is a central part of the AI4PEP mission, where we aim to apply AI methodologies for positive change in global health systems. So thank you all so much for being here to listen and engage with this conversation. We encourage you to continue adding questions to the chat or raise a hand as we transition to the panel Q&A session. So great, I will now move on to the panel Q&A. I'll go back through the chat and see what questions we have for our esteemed panel. But first of all, I'm trying to find it, but there was a commendation for Dr. Patricia. Yes, from Dr. Sergey Demidenko, who commended the use of acoustic-based AI-enabled analysis. And I see a raised hand. We have a hand raised from Aymane Siari, so feel free to ask a question. Hello, Dr. Aymane?
Hello.
Hello.
Thank you for this webinar. I have just a question for Dr. Mohammed from Morocco. Dr. Mohammed, est-ce que vous m'entendez?
Oui, oui, bien sûr. Allez-y.
En bref, je suis Sir Ayman. Je suis un jeune diplômé avec le diplôme Master Business Intelligent et Big Data Analytics à l'université Chouaib de Cali. J'ai déjà travaillé sur un projet de la détection de la tuberculose et pour le diagnostic de cette maladie, j'ai travaillé euh, sur ce projet j'ai fait un entraînement avec deep learning sur un data existe sur Kaggle avec des modèles de deep learning. J'ai trouvé des résultats qui est bon, mais j'ai rencontré un problème pour le data. Le data existe sur Kaggle et le data c'est juste des radiographies, des screens de radiographie. Et ce
Ouais.
data donne des mauvaises qualités. Pour cela, j'ai une question. Est-ce qu'il y a un data existe dans votre laboratoire, data sous forme numérique, comme DICOM ou d'autres types de data? Est-ce que...
Oui, bon, je peux répondre éventuellement. Alors,
Mhm.
vous voulez que je peux répondre maintenant?
Oui, oui,
Oui. Alors, d'ailleurs, quand nous, on a des datas sur tout ce qui est résistance et ce qui est épidémiologie. Et nous avons des collaborateurs avec qui on travaille et avec qui on a discuté pour l'obtention de data numériques pour tout ce qui est radiologie, également l'âme de bacilloscopie. Mais ça fait
oui,
partie du projet. Ça fait partie du projet AI4PEP dont le professeur Yahya Tayalati a fait mention et a présenté. Et nous sommes en train de générer donc la base de données, de la préparer, parce que quand on a intégré ce projet, c'est pour c'est d'abord mettre à profit donc l'équipe projet des données que nous avons, mais également des collaborateurs que nous avons pour essayer de disposer de data assez exhaustifs pour essayer de mener et d'élaborer des algorithmes IA avec c'est le projet dont le professeur Yahya Tsayalati a présenté. Donc, oui, il y a des datas, mais bon, il y a un projet autour de ces datas. Et pour qu'il n'y ait pas de redondance, il faut voir comment on peut les travailler ensemble. Pas...
ouais. Pour le data radiographique, n'est-ce pas?
Alors, nous avons. Alors, parce que, bon, en termes de data de TB, il y a plusieurs datas différentes. Bon,
Oui,
quand on parle de radiographie, c'est des datas d'imagerie.
oui,
Donc,
l'imagerie.
c'est l'imagerie. Quand on parle de bacilloscopie, c'est des tas d'images de l'âme. Quand on discute d'épidémiologie, c'est des données que nous avons générées, que nous avons trouvées, que nous avons publiées. Et en termes de résistance, c'est des données de mutation génétique et de profil génétique. Et on va compiler toutes ces données pour essayer de sortir le maximum d'informations pour la gestion de la tuberculose et comment prévenir. Alors, quand on parle d'épidémiologie, c'est surtout la prévention. C'est comment se projeter dans le futur pour essayer d'avoir une idée sur l'évolution probable du tableau épidémiologique actuel. Quand on, pour tout ce qui est radiologie et l'âme de bacilloscopie, c'est comment aider le patient à lire les lames ou à lire les radios pour une meilleure exploitation des données. Donc, on est en train de fédérer tout ça et ça fait partie du projet qui nous réunit dans le cadre de AI4TV. Donc, il y a
Oui.
plusieurs types de data et différentes. Il n'y a pas que les lames, il n'y a pas que les clichés radiologiques. Il y a plein d'autres choses et c'est ce qu'on est en train d'expliquer. C'est tout disons le travail de ce groupe.
Ok, ok, je comprends. Merci, Monsieur Mohamed.
Merci, merci beaucoup.
Ok, merci.
Thank you for your question. So we also had a question in the chat or a comment. let me just find it. Yes, from Dixon, Shane, Saga to everyone. They read a report today on a 10% increase in child tuberculosis in the EU region of the WHO, and they were asking for the panel to respond if anyone has any idea why there's this sudden increase in child incidence of TB, and are people observing a similar situation prevailing in the global south? So I leave that to everyone to respond. Does anyone have a comment?
I can take it if you want.
Okay.
Okay. I read also this news, and according to World Health Organization in the European regions, which include more than 50 countries across Europe and also Central Asia, they recorded something like more than 7,000 TB cases in children under 15, and this represented about 10% increase. So according to the same source, I mean, according to the World Health Organization and its experts, so the rise in cases may be due to many factors. The first one is we have now better diagnostic tools, so we are more efficient in detecting TB. So this could justify the increase. Furthermore, unfortunately, to the war in Ukraine, we have this increased cross-border movement, and Russia and Ukraine being both high TB burden countries. So this could also explain the situation. And this is an alarm from the health organizations. So the potential underfunding of TB programs, so the funds for TB detection and fight has decreased a little bit. So this may be limiting prevention and treatment efforts. So I think this is a wake-up call showing how fragile recent progress is, especially for disease that is preventable and curable. So I think we should keep funds for TB fighting and so on. So there were many factors highlighted by the health organization, but I think this is the most three important ones that could justify this 10% of increase in TB in Europe for child. I hope I answered the question.
Thank you for that response. Does any other panelist have a comment?
Can I give more information about this?
Sure.
Oh, alors, there's another point of view. After the COVID, there is a decrease in vaccination of child, and in many countries, this decrease is accompanied with tuberculosis, but also measles, and there are other diseases that were prevented by vaccination. But after the COVID, most people don't accept to vaccine their child, and there is a recrudescence of some infections and some diseases.
Thank you for those comments. We also had another. Well, first of all, do anyone else want to add to that thought? If not, we have another question or comment really from Dorai Suresh, directed at Dr. Yaya Tailati. They said that they are from India and are interested in joining AI4TB. I want to know what the process is like for joining the consortium.
Yeah, I think we are, thanks a lot for this suggestion. So we are open. I mean, if he could contact us by email, we will be very happy to start to collaborate with with India also. I mean, I don't know what's the status of the if he is a PhD student. I mean, but for sure we can find a way to collaborate. He needs to contact us by email. I can leave my email in the chat if he is still connected.
Sure. Thank you. All right. I'm not seeing any more questions in the chat. But so if anyone else wants to raise their, oh, I see a new message. Oh, I think that's your email. But if anyone wants to raise their hand and ask a question, if not, I believe, I actually had a question, for Dr. Hasiru. You commented a lot in your presentation about surveillance and like the kind of distrust model with your patients versus using AI towards having a collaborative role with patients in terms of like ensuring treatment adherence. And I was wondering if you'd like to comment more about how we can sort of design AI methodologies and systems that support and have an empathetic response to patients' needs during their treatment to support TB treatment adherence. If you have any thoughts.
Yeah, sure. My comment is that any system at any state or at any country is different, and so does the patients there, and so does the limitations there. So whenever a system such as what we've made here in Malaysia did, it can work out differently for other settings, right? But in terms of TB and in terms of compliance, I think the approach can be the same. We can leverage a free yet an open source platforms that really are abundant now, and with no coding ability, any country or any organization can adopt this. And in terms, get those platforms ready, abide by the laws of especially medical related laws, and get the intervention be a prioritization for that system. We don't want just another system. We don't want just another SOP or another protocol to be stepped on. We want to replace or a combination of a previous SOP to be merged into one, so that any, for example, for defaulting episodes, if a patient were to default, the intervention can be the priority, and we can focus on getting our patient back on track. And that should be the main focus, and that should be the main monitoring. And the monitoring aspect will be in terms of how fast we get to our patients, how effective we get to our patients, and worked it all out on the go. Because as I mentioned, the limitation shall be different, patients' assumption shall be different, the insight will be different, the taboo may be at varying degrees, but NGOs are freely available, and they need to know, and this is a good platform for them to communicate as well. So that's my thought for now.
Thank you for those great comments. We have a question from Dr. Al-Mzibri to, I believe, probably to Dr. Tani, Dr. Sagna, for Burkina Faso. They are asking, the high mortality rate is due only to TB, or is it also due to double infection with malaria or HIV?
Thank you for your question. Do you hear me?
Yes, we can hear you.
Yes.
Okay, good. So the high mortality rate is not only for due to TB, because we have a confection with HIV, and about the TB, we have a resistance, a lot of resistance, the loss to follow up, and some cases not reported. Yeah.
Thank you for your response. Dr. El-Mzibri, do you have anything to add to that?
No, just because there is only 44 cases notified about 100,000 people. So it's lower than in Morocco, but the mortality is higher. And maybe there are other factors affecting the mortality than only TB. That's why I have given the question.
Okay, the National Tuberculosis Program also reported about nutritional. So in the follow-up, they support by food to the TB, infected TB people. But sometimes it is not very focused on the TB pupil, but they give the food, but the TB pupil take the food and do other things with the food, not to themselves. So they are about nutrition and yes.
Okay, thank you so much, Dr. So if there are no other questions in the chat, I just had one final question. I'll direct it at Dr. Patricia and then to everyone. But if you had any comments related to, or also Dr. Tayalati because of the consortium, but do you have any thoughts, final thoughts on the potential for collaboration across regions and how we can consolidate and combine knowledge and resources to democratize AI tools to meet the TB crisis? If you have any thoughts on how the global south can come together around sharing resources to address the gaps.
Thank you, Taylor, for the question. What I can say about this talk about collaboration is the first goal maybe is that we are joined together in this fight against TB. As you can see in the global south, we have like a high burden settings with a lot of people living with TB. So we are joining this fight together. That's one of the main reasons we are doing like AI implementations, tools to bridge these gaps in the access to care. So if we can still work in, we have this consortium of the AI4PEP. We are working in different kind of AI innovative tools, maybe not only focusing the ones that we have previously have mentioned, but we are trying to address the different stages of the TB care, diagnosis, screening, predicting modeling, as well as maybe using GIS, etc. That's one of the main areas to work together. And definitely another maybe challenge, but opportunity is to, if we can still working in different areas of the global south, we are enriching these AI algorithms. We are collecting a large data set that can be used in the future to have like a really strong AI tool to use for the TB population. So we are still collecting data. We need to be aware as well of the data sharing using AI solution as well. So these are just opportunities with the Global South collaborators. And definitely, if there is anyone who wants to join to the different countries in the AI4PEP consortium, it's completely awesome for us to hear about these new approaches or new ideas from people around the globe in this fight against TB. So thank you.
Thank you, Dr. Patricia. Does anyone have anything to add to that? If not, we have a additional question in the chat. All right. So I'll read off the next question. So from Jacob Tong Duong Attack, they ask, is AI-based TV solutions at the experimental stage right now, or are they already in use? What steps are needed to scale AI-based TV solutions globally, and what partnerships? I believe we've touched on this, but if anyone wants to respond to that question. I can repeat it as well. I said that kind of fast. But they're asking basically what are the steps that we would need to scale these solutions globally, and what kind of partnerships need to form in order to make change happen at a large scale. If anyone has any comments. I'll actually throw this one to Dr. Yaya because of the TV consortium. Do you have any thoughts about this, since your focus is on building such a consortium in Africa?
I was muted, sorry. So thanks a lot, Dr. Jacob Tong Duong, for these questions. I mean, as you noticed along this event, there are many initiatives where we have started already to explore artificial intelligence techniques worldwide. I mean, you had seen from my colleague Patricia presentation, they explore already artificial intelligence techniques in order to analyze cough, in order to do many things to fight the TB. So yes, the answer is yes. But in order to globalize this approach, there are many major steps we have to overcome. I know that Jacob is based in Morocco. So for the case of Morocco, we need to convince our stakeholders that we have a lot of opportunities with artificial intelligence to fight the TB. So there are a lot of things to do at national levels and also at international levels. But yes, we have some countries that already adopted the AI for the TB fight. Yes.
Thank you, Dr. Tayalati, for that comment, and thank you to all of our attendees for these great questions. For the sake of time, because we definitely have gone over time a bit, but thank you so much for participating. We're going to transition to a quick closing remarks. But sorry, let me just make sure you can see my screen. But yeah, onto the closing. I would definitely like to say thank you so much to our amazing speakers and panelists for your engaging contributions to this important conversation. I'll leave space right now if any speakers have any final comments, or at points that they'd like to emphasize before we fully close.
Yeah, I think Dr. Taylor, if you allow me, I can maybe. So as we move forward, I think one of the most urgent needs is the creation of a dedicated TB data and artificial intelligence innovation center. I don't know, maybe could be like African one or worldwide. So I believe this platform where we can host and where we can share and when we can analyze TB data, of course, securely and ethically, is something that could push up and boost up all our effort. So in the case of Africa, we have many initiatives. We have PhD students from, for example, from Burkina, and they are suffering from the lack of computing resources. So, and I think if we have such international center which can provide you know, this youth with computing facilities, I think we can, that will bring a good help for IA4PEP and especially for IA4TB. And I'm pretty sure, I'm convinced that IRDC could play a major role to achieve this. So that this is, I have highlighted this last year, and I do it also this year. So I believe together we can build not only models but momentum, and together we can go beyond pilots and just building platforms. So in my opinion, and then after this modest experience with our collaborators in Africa, I think there are a real need to democratize, if you would like to see it like that, computing resources, data resources, and so on. Thanks a lot. That's the message from
Thank
my
you.
side.
Thank you for that great comment. I think that summarizes everything wonderfully. But yeah, so thank you so much to our amazing speakers, our panelists, and thank you to all of our attendees for participating. This is actually the second annual World TB Day event held by AI4PEP, so this is definitely exciting. Also would like to thank our event organizers, including our event planning committee, especially Dr. Musa, Dr. Gela Narayana, Dr. Sergey Demidenko, Dr. Guillermo Caceres, Manal, and Hajar, as well as our communications team, especially Mediatrice, for helping make this event possible. And AI4PEP would also, as always, like to thank our partner organizations who are shown on the screen: University of Toronto, the Africa-Canada Artificial Intelligence and Data Innovation Consortium, Dalalana School of Public Health, the IDRC, the UK International Development Organization, York University, and CFAL York. So just final comments, please, if you are able, please take the time to fill out the participant feedback form, which has been shared in the chat. You can find our social media connections on the QR code on the screen or in the bottom corner. So please stay connected with us beyond this event so we can continue these kinds of conversations and collaborations around not only how AI can revolutionize TB treatment and response, but other healthcare systems as well. So thank you so much again, everyone, for attending, and thank you so much to our amazing panel for your comments and your engagement. With that, I think we can wrap up the event. Thank you everyone for joining, and enjoy the rest of your day.